morning, everybody. Today we will start large intestine. Before that, we will have a small review of the small intestine, which was completed yesterday. Small intestine is about 6.5 meters in length, out of which duodenum is about 50 centimeters, and the other things, the jejunum is 3 meters, and ileum is 2 meters, and then duodenum is the fixed part, which is wider and having a C shape, and it encloses the pancreas in a C shape. Then the most important thing in duodenum is the second part of the duodenum, which is the vertical part, is having a major duodenal papillae and a minor duodenal papillae. The major duodenal papillae is allowing the pancreatico-duodenal thing, the hepatopancreatic duct, to open through it, such that the secretions of the liver as well as pancreas are coming into the duodenum through this one. And the minor duodenal papillae, which is about 6 to 8 centimeters from the pyloric sphincter, whereas the major duodenal papillae is 8 to 10 centimeters from the pyloric sphincter, and this minor duodenal papillae is about 6 to 8 centimeters from the pyloric sphincter, and it is having opening of the minor pancreatic duct, which is the duct of the accessory pancreatic gland, if at all present. So the other things are not much important. Important thing is here, only thing, the opening of the pancreatico-duodenal duct into the second part of the duodenum, and of course the C shape of the duodenum, which is enclosing the pancreas in its concavity, and third and fourth part are not much important. Now we go for the large intestine. So large intestine extends from ileocecal junction to the anus. So the small intestine is extending from the pyloric sphincter of the stomach to the ileocecal junction, that is the ileum entering into the cecum. So from this ileocecal junction, we call it the large intestine up to anus, the last part. So large intestine is length about 1.5 meters. The function of large intestine is chiefly absorption of fluid and solid. So by the time the food that is taken into the mouth has been digested and absorbed during its journey through the mouth, in the mouth itself the digestion starts, then in the stomach, then in the small intestine, the duodenum, jejunum, ileum, wherein we are seeing the major part of the digestion and absorption. So everything is all the nutrients are absorbed by the time it reaches the large intestine, and in the large intestine only fluid is absorbed, that is remaining in excess in the residual part of the food that we have taken, which has passed through all the small intestine. Now large intestine is subdivided into, this is the important thing, because whenever there is a question on GIT, you will be given question like that, name the parts of GIT, then we have to mention about a large intestine or stomach or duodenum, something like that, or esophagus. So now again I repeat the various parts of the GIT, gastrointestinal tract. Mouth, starting with the mouth is having a vestibule and oral cavity. In the oral cavity we are having the tongue and teeth, then pharynx, then esophagus, then stomach, then small intestine with the duodenum, jejunum and ileum, and large intestine with cecum, vermiform appendix, ascending colon, transverse colon. Okay, in between ascending colon and transverse colon you can write hepatic flexure, then transverse colon, then the splenic flexure, then descending colon, sigmoid colon, rectum, anal canal. In the large intestine, we see that the cecum is about 6 centimeters length and it is wider than its length, about 7.5 centimeters wide. And vermiform appendix is an extension, is almost a projection from the cecum. Very vermiform means like a bomb, very thin, like a bomb, and appendix is an extra. So vermiform appendix is a part that is coming from the base of the cecum, and it's about 9 centimeters length. Then ascending colon, cecum continues upwards as ascending colon. Then we are having the hepatic flexure. That means the ascending colon turning to the left to become a transverse colon. So at that junction we are calling it as hepatic flexure. Then transverse colon. Again this transverse colon is going down. So there is again a splenic flexure and descending colon is there, and of course sigmoid colon, rectum, anal canal. So these are the various parts of the large intestine. So CAECUM, vermiform appendix, ascending colon, transverse colon, descending colon, and sigmoid colon, rectum, and anal canal. Characteristic features of the large intestine. So the large intestine, as we know that it is the last part of the GIT. So it is structurally adapted for the storage of the fecal matter and for absorption of fluid and solutes which are remaining in it. So after all the digested food and the useful part of the digested food is absorbed in the upper part, that is the stomach, duodenum, jejunum, ileum, and then you are having a few amount of fluid and some of the minerals that are in the fluid, that are dissolved in the fluid, you can say. And so we are telling that here the large intestine is absorbing fluid and solutes, that means some minerals that are dissolved in this fluid. Now villi are absent here. The mucous membrane present plenty of mucus secreting glands. So villi are absent means there is the surface area of the large intestine is not much increased. It is as the lumen itself, because in the small intestine we need absorption of more material. So there are the plica circularis and villi to increase the surface area to get the more of the food exposed to the mucous membrane, such that absorption is almost complete and quick. Here, because not many things are to be observed here except the fluid, so there are no villi, there are no plica circularis. Instead, we are having plenty of mucus secreting goblet cells. What is the function of this mucus? This mucus is a lubricant which allows easy passage of this, completely digested, and of course the waste part of our food can be easily pushed through this large intestine because of this mucus secretions of the goblet cells. The large intestine is wider in caliber than in small intestine. Greater part of large intestine is fixed except the appendix, transverse colon, and sigmoid colon. So in the large intestine, as we studied, the CAECUM is fixed, the ascending colon is fixed, the hepatic flexure is fixed, whereas the transverse colon is mobile, and again splenic flexure is fixed, descending colon is fixed, sigmoid colon is mobile, and of course the rectum, anal canal again fixed. So only the appendix, the transverse colon, and sigmoid colon are mobile, whereas all the other parts are fixed. Now, tinea coli are aggregations of outer longitudinal muscle coat. There are 3 in number: tinea libera, tinea fomentalis, and tinea colica. See, yesterday when we read about the structure of the wall of the small intestine, we studied that mucosa containing the epithelium, the lamina propria, muscularis mucosa, then submucosa, then muscularis proper. In the muscularis proper, we read the inner circular, outer longitudinal muscles. After that, serosa is there. Here also we are having inner circular and outer longitudinal muscles in the large intestine also. But the thing is that in the large intestine, the outer longitudinal muscles are concentrating at 3 points. We are calling them as tinea. Tinea libera anteriorly, tinea fomentalis towards the omentum, and tinea mesocolica towards the other side. So we are having tinea libera, tinea fomentalis, and tinea mesocolica, the condensed part of the large intestine, as outside as the outermost covering of this large intestine. And here the thing is that the tinea are comparatively having less length than the large intestine. See what they say is the tinea is about 4 feet in length, whereas the large intestine is 6 feet in length. So this 6 feet length large intestine has to be arranged, has to be fixed in tinea of the 4 feet. So to accommodate this, the large intestine is undergoing folds, thus producing saculations. See here, we have to give an example of a purse string suture or the grandma's purse. So here, see, if you put thread like this and then tighten it, a small length of the thread can accommodate the whole circumference of this circle. So that is purse string. So the same arrangement is there. The tinea is 4 feet length, whereas the large intestine is about 6 feet length. To accommodate this, there is sacculation of large intestine. Same thing again, they have tied it and it is there. Then this is 6 feet large intestine and 4 feet tinea. Then appendix epiploicae. So these are the appendix epiploicae. Appendix epiploicae are peritoneal pouches containing fat. They are absent in cecum, appendix and rectum. So you are not seeing appendix epiploicae in this part, cecum, whereas it is seen in the ascending colon, transverse colon, descending colon and sigmoid colon. You will not be seeing it in the cecum, rectum and anal canal. Of course, appendix also you are not seeing appendix. Then the blood supply is derived from the inferior mesenteric artery and the veins drain into the inferior mesenteric vein, which finally drains into splenic vein. So the blood supply to this large intestine is from inferior mesenteric artery, and the draining also will be into the inferior mesenteric vein, which is draining into the splenic vein and thereby to portal vein. Now applied anatomy. So colitis is irritation of the colon leading to the abnormal bowel function. So colitis is irritation of the colon either due to infection or due to some irritant material that is taken in or given by enema. So these things can irritate the colon and may produce colitis. This will lead to abnormal bowel function. Maybe it is a diarrhea or maybe it is a constipation. Then gastroenteritis, vomiting and diarrhea caused by extremely powerful irritant stimulus. Again, gastroenteritis means here the gastric part, the stomach, the small intestine or the esophagus, from esophagus onwards are irritated, as well as the large intestine is irritated, so that there is a vomiting as well as there is a diarrhea. This will be because of some toxic material that is taken as food. Suppose a spoiled food, a food that is infected, a food that is infested by the organisms, it can produce this gastroenteritis. Enteritis is irritation of small intestine by toxins or other irritants. Again, enteritis is only irritation of the small intestine. So you are having colitis, gastroenteritis, enteritis as the clinical aspect of this large intestine. Now we come one by one. Cecum. Cecum is the first part of large intestine. It's about 6 centimeters in length and 7.5 centimeters in breadth. I told you the ileum is ending and opening into the wide part of the large intestine, which we are calling as cecum. It is wider than its length. So cecum is about 7.5 centimeters breadth and it's about 6 centimeters in length. It lies in the right iliac fossa. Shape of the cecum varies and is as follows. Fetal type, it is only 2%, where the appendix arises from the apex of the cecum. Infantile type, where it is only 3%, where the appendix arises from the depressed bottom of the cecum. Normal type, 90%, where the appendix arises from the posterior medial wall of the cecum. And exaggerated type, 4 to 5% only, where it arises from very close to the ileal attachment. So we will be showing the figures of the 4 types of the Cecum. First thing we will show the surface anatomy of the cecum. Cecum, this part is the blind sac which is wider than its length. It is seen as the surface anatomy. It is seen that it is below the transtubercular plane, that is the ileal tubercles on either side. If you join a line from these two tubercles, it's at the level of L5, and if you draw a line of lateral plane, that is the mid-clavicular, right, coming downwards. So at this quadrant, that is in between the transtubercular plane, the left lateral plane, and the, of course, this is the the brim of the pelvis. So in between this area we can find the cecum. Here also we are showing the base of the appendix, so, and the base of the ileocecal orifice. So in the transtubercular plane we are seeing the ileocecal orifice at the junction of the right lateral plane and the transtubercular plane, whereas 2 centimeters below that, in the right lateral plane, we are seeing the base of the appendix. And we are also here seeing the McBurney's point is the place where a maximum tenderness can be felt in case of appendicitis. This is at the junction of the medial 2/3 and lateral 1/3 of a line joining the anterior superior iliac spine to the umbilicus. This is, you can say, spino-umbilical line, and on it medial 2/3 and lateral 1/3 is joining at a point where we are seeing the McBurney's point. So here we are seeing the surface anatomy of the cecum. Cecum is present below the transtubercular plane and to the right of the right lateral plane. And then we are seeing the orifice of the ileocecal and appendix, which is present in the plane of the right lateral plane. One is at the junction of the right lateral plane with the transtubercular plane, and the base of appendix is 2 centimeters below this ileocecal orifice. Then we are seeing the McBurney's point, which is at the junction of the line joining anterior superior iliac spine to the umbilicus at medial 2/3 and lateral 1/3. This is the McBurney's point. Now we are seeing the types of cecum. Here the first one is the fetal type, wherein the tip of the cecum is continuing as the appendix. This is fetal type, which is only seen as 2%. And infantile type, wherein the base of the cecum is broad and there is a depression in the center, and from that depression the appendix is coming out, and we are calling it as the infantile type. Then we are seeing the adult type, wherein the appendix is seen between the medial and lateral halves of the base of the cecum. Whereas the exaggerated type, where we will be seeing the appendix more towards the ilium. So this is the most normal, wherein we will be seeing the base of the cecum getting depression at the middle from where the appendix is coming out. Again. So here in the fetal type, the appendix arises from the apex of the cecum. In infantile type, appendix arises from the depressed bottom of the cecum. Cecum will be broad and there will be a depression in it. In normal type, appendix arises from the posterior medial wall of the cecum, whereas in exaggerated type, appendix arises very close to the iliac attachment. That's what we have seen. This is very close to the iliac attachment. And now the interior of the cecum is continuous above with the ascending corner. So cecum is a wide sac-like structure which is continuing upwards as the ascending colon. The ilium opens into the cecum at ileocecal orifice, which is guarded by ileocecal wall. It prevents reflux from the cecum to the ilium. It regulates the passage of ileal contents into the cecum. So into the cecum, we are seeing that there is a ileocecal opening through which the ileum is opening. As just now we have seen in the surface markings that this ileocecal opening is present at the junction of the transtubercular plane and right lateral plane. So this ileocecal orifice is present at this junction on the wall of the cecum, and its function is to prevent reflex from the cecum to the ileum. Of course, this will be allowing the material from the ileum to the cecum. At the same time, it will prevent the reflex of the material from cecum back into the ileum. And appendix orifice is 2 centimeters below the ileocecal orifice on the posterior medial wall of the cecum. It is supplied by the ileocolic branch of the superior mesenteric artery. So this appendix is present 2 centimeters below the ileocecal orifice in the right lateral plane, and it is present in the posterior medial wall of the cecum. Then this cecum is supplied by ileocolic branch of the superior mesenteric artery. So here we are showing this is the ileocecal wall, which can control which can stop the reflux of the material from cecum to the ileum, and it can allow the material to come into the cecum from the ileum. And then the other one is the opening of the appendix, orifice of the appendix, which is also guarded by a wall called Gahat's wall. Now the relations of the cecum. Cecum is related anteriorly, that means anterior to cecum we are having the small intestine, sometimes parts of greater omentum and anteroabdominal. So in the right iliac fossa, we are having the anterior abdominal wall. Behind that there may be a part of greater omentum, and behind that we are seeing coils of small intestine, and finally we are seeing the cecum. And posteriorly, that is behind the cecum, we are seeing psoas and iliacus muscles, the femoral nerve, the lateral cutaneous nerve of thigh, and appendix is commonly found behind the cecum. So appendix is mostly retrocecal. So it is also found in the posterior aspect of the cecum. Apart from that, you can see the psoas major muscle, iliacus muscle, femoral nerve, and lateral cutaneous nerve of the thigh. So these are the posterior relations of the cecum. Anteriorly, we are seeing the anterior abdominal, greater omentum, and the coils of the intestine. Whereas posteriorly, we are seeing the psoas and iliacus muscles, femoral nerve, lateral cutaneous nerve of the thigh, and sometimes appendix. Medially, appendix arises from the cecum on its medial side. So that's about the cecum. So now we know that cecum is the first part of the large intestine, wherein the ileum is opening into the cecum through the ileocecal wall. This ileocecal wall is present at the junction of the transtubercular plane and right vertical plane, right lateral plane. Okay, the right lateral plane. So then below this ileocecal opening, we are seeing the opening of the vermiform appendix 2 centimeters below this opening. And then the cecum we are seeing as surface anatomy in a quadrant that is bounded superiorly by the intertubercular plane, laterally by the right lateral plane, and of course the other part is by the brim of the pelvis. So that quadrant we are seeing the cecum. Then cecum interiorly we are having the ileocecal opening and as well as the opening of the appendix. And then types of the cecum. Cecum are 4 types: infantile type, the fetal type, infantile type, the normal, and the exaggerated. We have seen the figures. And now we go for the vermiform appendix. Vermiform appendix is a narrow vermiform tube which arises from the posterior medial cecal wall, 2 centimeters below the ileocecal opening. So you have to remember, it is a worm-like narrow tube which arises from the posterior medial aspect of the cecal wall, 2 centimeters below the ileocecal opening. So it is a narrow tube-like structure, arising from the posterior medial wall of the cecum 2 centimeters below the ileocecum. Its length is about 2 to 20 centimeters, average 9 centimeters. It has three parts: base, body, and tip. Appendix is having three parts: base, body, and tip. Now, appendicular orifice is situated below the ileocecal orifice. It is occasionally guarded by a valve of Gerlach, G-E-R-L-A-C-H, valve of Gerlach. The orifice is marked on the surface by a transtubercular and right lateral plane. I told you the orifice of the ileocecal valve is at the level of the cutting of the transtubercular plane and right lateral plane. Whereas the orifice of the appendix is just 2 centimeters on the right lateral plane, below the 2 centimeters below the ileocecal valve on the right lateral plane. So here we are showing the base of the appendix. This is the transtubercular plane conducting the tubercles of the ileum on either side, and this is the right lateral plane, that is a perpendicular drawn from the mid-clavicular line to the pelvis, and then at this junction we are seeing the ileocecal orifice. 2 centimeters below this ileocecal orifice we are seeing the base of the appendix on the right lateral plane. Now here the dissection, we are showing the vermiform appendix on the posterior aspect. We say that it is a retrocecal appendix fixed on the posterior aspect of the cecum. Now positions. Depending on the position of the tip of the appendix is classified as subcecal or parabolic, retrocecal, ileal or pre and post, and promantric, pelvic, medial. So these are the various positions: subcecal, retrocecal, ileal, promantric, pelvic, and medial. Here we are showing this is subcecal. Okay, retrocecal. This part is the subcecal, which you are seeing just below the cecum, and this is the retrocecal, and then we are seeing the pre-ileal and post-ileal, then promantric, pelvic. So these things just try to remember, or you have to, if you remember this figure, it will be easy for you. Please don't worry. Now, it has a complete peritoneal covering, which is attached to the mesentery of the small intestine by a short mesentery of its own, the mesoappendix. So this appendix is completely covered by a peritoneum, which is attached to the mesentery of the small intestine. So this mesentery of the appendix we are calling as mesoappendix. The appendix lies in the right iliac fossa and in relation to the anterior abdominal wall. Its base is situated 1/3 the way of the line joining the right anterior superior spine and umbilicus, McBurney's point. So McBurney's point is where on a line between the anterior superior spine and umbilicus at the junction of the medial 2/3 and lateral 1/3. This is the umbilicus, this is the anterior superior spine, and medial 2/3 and lateral 1/3. Here we are seeing the McBurney's point. McBurney's point is one wherein we are seeing the maximum tenderness in case of acute appendicitis. Appendicitis is inflammation of the appendix. The inflammation of the appendix is known as appendicitis. Pain is felt first around the umbilicus, then to the right iliac fossa. So remember, if a person comes with a pain in the around the umbilicus, pain around the umbilicus, see, he will be probably telling you pain around the umbilicus, pointing at the epigastrium almost. So what we feel that it may be due to gastritis and we are giving some antacid and giving him. Not like that. You just ask him, to stay in the hospital for 1 or 2 hours, then after that you will be seeing that the pain will be concentrating on the right iliac fossa, wherein you can see the McBurney's pain, the tenderness in the McBurney's point. So the pain of the acute appendicitis first starts around the umbilicus, then it migrates to the right iliac fossa. So this pain is followed by vomiting and fever, that is Murphy's symptoms. If the removal of appendix is not done immediately, then there is a chance that the appendix may rupture and leading to the peritonitis. This is a severe complication. Or gradually it may subside and form a tender fixed lump in the right iliac fossa. That is a chronic complication. So there is a acute complication wherein the appendix can rupture and leading to the peritonitis. And there is a chronic complication wherein this appendix gradually subsides and forms a lump in the right iliac fossa. So appendicitis is the inflammation of the appendix, that is the pain of which is first felt around the umbilicus and then migrates to the right iliac fossa. Then the pain is followed by the vomiting and fever, that is Murphy's symptoms. Then if a person complains of the pain in the right iliac fossa, then vomiting and fever, you can elicit a McBurney's point, then you can say that it is definitely the acute appendicitis which needs immediate removal. If it is not removed immediately, there is a chance that the appendix may rupture leading to the peritonitis. It is a grave symptom. Peritonitis is a very dangerous condition wherein the infection is spreading throughout the peritoneum and it needs hospitalization, much longer treatment. Before that, if you remove the appendix, it is very easy. Otherwise, sometimes if the patient is strong enough, resistant, it may develop as a fixed tender lump in the right iliac fossa. Now ascending colon. So after CAECUM, vermiform appendix, we go for the ascending colon. It extends from the CAECUM to the under surface of the liver, where it turns to the left as transverse colon. So from the CAECUM it is going till it reaches the under surface of the liver. From there it is turning left to go as transverse colon. Here we are seeing the hepatic flexure. The junction is called right flexure of the colon or hepatic flexure of the colon. Ascending colon is about 15 centimeters length and it is retroperitoneal and fixed. So appendix is a retroperitoneal structure and it is fixed. It's about the 15 centimeters in length, whereas the CAECUM is about 6.5 centimeters only. Transverse colon. It is suspended in the cavity of the abdomen by a fold of peritoneum called transverse mesocolon. It extends from the hepatic flexure of the colon to the splenic flexure, from where it is continues down as descending colon. The transverse colon is about 50 centimeters in length. So the CAECUM is going as appendix colon, ascending colon. From the ascending colon there is hepatic flexure, and hepatic flexure is turning towards the left, wherein it is becoming a transverse colon. The transverse colon is suspended in the abdomen. It is freely moving. It is suspended by a peritoneum called transverse mesocolon. This transverse mesocolon allows the transverse colon to move in the abdominal cavity. Then it extends up to the splenic flexure, where it is continuing down as the descending colon. This transverse colon is about 50 centimeters in length. See here we are showing. This part is the CAECUM, and of course you are seeing the vermiform appendix also here. This is the ileocecal opening, that is the ileum opening of the CAECUM, and then this part is the ascending colon, is about 15 centimeters length, and it is going behind the liver, forming the hepatic flexure. From there it is turning to the left as transverse colon, and below the spleen it is turning down as descending colon. Then of course the sigmoid colon, the rectum, and the anal canal anus. So here what we are seeing is the ascending colon is taking a bend to the left below the liver. So we are calling it as hepatic flexure here, and then it is coming to the left until it reaches the space below the spleen, where we are seeing it as a splenic flexure and continuing down as descending colon. This transverse colon is about 50 centimeters in length, and it is suspended by a mesocolon, that is a peritoneal fold, mesocolon, and it is mobile in the abdominal cavity. Now descending colon. It extends from the splenic flexure to the left pelvic brim, where it continues as sigmoid colon. So from the splenic flexure it is coming till it reaches the pelvic brim, from where it continues as sigmoid colon. So this part we are calling as descending colon. It is about 25 centimeters long and is retrovertebral. Descending colon is also retrovertebral. So sigmoid colon begins at the left pelvic brim and ends in front of the third sacral vertebra. So sigmoid colon begins at the left pelvic brim and ends in front of the third sacral vertebra. Its average length is about 40 centimeters. It is suspended from posterior pelvic wall by a peritoneal fold called sigmoid colon. Oh, sigmoid means a shape, S-shape. The S-shaped colon, this part. This part, sigmoid colon, is suspended from the posterior abdominal wall, and this is having one anterior curve and one posterior curve. This is the sigmoid colon we are seeing, and this is about the 40 centimeters length, suspended by a sigmoid mesocolon, and it is a mobile part. Now rectum. It is the lower dilated part of the large intestine and is present in the pelvic cavity. So rectum is present in the pelvic cavity. It is lower dilated part of the large intestine, and it measures about 12 centimeters in length. It extends from sigmoid colon to the anal canal at anorectal junction. The lower end of the rectum dilates to form rectal ampulla. Interior of the rectum shows 4 mucous folds, Huston's walls. So the rectum is a dilated part of the large intestine and it is present in the pelvic cavity. So it measures about 12 centimeters in length, extends from sigmoid colon to the anal canal at the anorectal junction. Then the lower end of the rectum dilates to form the rectal ampulla. The interior of the rectum shows 4 mucous folds called Huston's walls. So this is we are showing the rectum, and this is showing the mucous folds, almost 1, 2, 3, and this one is the fourth one. 4 mucous folds, and which are called Huston's walls. And the function of these mucous folds is to support the fecal material that is present inside the rectum. Of course, this is the rectal wall we are showing again. In the male, the rectum is related anteriorly to the urinary bladder but separated by a rectovesical pouch. In the female, the rectum is separated from the uterus by the rectovitreal pouch. So here, the anterior relations of the rectum are different in the male and female. In the male, it is the urinary bladder, whereas in the female, it is the uterus. So here we are showing rectum. So here this is the section of the male pelvis. See, section of the male pelvis, wherein we are seeing the rectum, and anterior to the rectum we are seeing the urinary bladder. Whereas in the female pelvis, you will be seeing the rectum, then anterior to it you will be seeing the uterus, and then anterior to it you will be seeing the urinary bladder. And the uterus and rectum are separated by rectovitreal pouch. This part we are calling as the rectovitreal pouch, a peritoneal pouch. Whereas in male, this part we are seeing as the rectovesical pouch. So, in the male, the rectum is related anterior to the urinary bladder and separated by rectovesical pouch. In the female, it is separated from the uterus by a rectovesicular pouch. So, we are having a rectovesical pouch here, this part between the rectum and the rectovesical pouch, and in female, the uterus and the rectum separated by rectovesicular pouch. This part is the rectovesicular pouch. Now the last part is the anal canal and anus. Anal canal is the terminal part of the alimentary tract. It extends from the anorectal junction to the anal orifice, passing through the pelvic diaphragm. So this anal canal passes through the pelvic diaphragm. It is extending from the anorectal junction to the anal orifice. It's about 3.8 centimeters in length, external length. The anal canal is surrounded by internal and external anal sphincters. So this anal canal is about 3.8 centimeters in length, and externally this is surrounded by internal and external anal sphincters. The internal anal sphincter surrounds the upper part of the anal canal. It is made up of smooth muscles fibers. It is supplied by sympathetic nerves. So the internal anal sphincter surrounds the upper part of the anal canal. It is made up of smooth muscle fibers. It is supplied by sympathetic nerves. The external anal sphincter surrounds the entire length of the anal canal. It is made up of striated muscles, that is voluntary muscles supplied by pudendal nerve. The external anal sphincter has three parts: subcutaneous, superficial, and deep parts. So here we are showing this is the internal anal sphincter and this is the external anal sphincter, whereas we are showing the subcutaneous part, the superficial part and deep part, three parts of the external anal sphincter, whereas the internal anal sphincter is a single one, and then this is surrounding this part is the anal canal. The interior of the anal canal is having three parts. The upper part is about 1.5 centimeters in length. Below it is limited by pectinate line. The mucosa shows about 6 to 10 vertical folds called columns of Marcagni. The mucous membrane deep to the anal columns present terminal radicals of the inferior mesenteric vessel. The lower end of the anal columns are connected by crescentic mucous fold called anal walls. So here anal column, these are the anal columns of the Marcagni, and then the lower part is supported by anal walls. So we are having anal, the vertical folds called columns of Marcagni. Then we are having the anal walls, crescentic folds. So these are crescentic means half moon shape. These are crescentic folds and these are the anal walls, anal columns. These are the anal columns and these are the anal walls. So columns are vertical, whereas walls are like a crescent at the base of this vertical columns. The recess above the walls is called anal sinuses. The mucous membrane is lined by simple columnar epithelium. Intermediate zone, it is transitional zone and is about 1.5 centimeters length. It extends from the pectinate line to the Hilton's line. It is lined by stratified squamous non-keratinized epithelium. Lower area anal wedge is about 8 mm in length and is lined by skin. So here this part we are calling it as intermediate area, which is lined by stratified squamous epithelium, and this is the anal wedge which is covered by skin. So skin, stratified squamous epithelium, then columnar epithelium. See, the mucous membrane is lined by simple columnar epithelium, mucous membrane of the anal walls as well as the columns. Then the intermediate part, pectinate part, is transition zone, is about 1.5 centimeters in length, extends from the pectinate line to the Hilton's line. It is lined by stratified squamous non-keratinized epithelium, and the wedge is lined by skin. So here, this is the pectinate line and this is the Hilton line. In between we are having area of stratified squamous epithelium, and this is the skin, that is the anus covered by skin, and this is the area of the upper part of the anal canal which is covered by the columnar epithelium, wherein we are seeing the columns of Margagni and the anal walls. These are all covered by the simple columnar epithelium, whereas this intermediate zone present between the Hilton's line and pectinate line, we are seeing it is covered by the stratified squamous epithelium, and the anal wedge is covered by the skin. So here we are having three types of coverings: the skin, stratified squamous epithelium, this part, and then simple columnar epithelium. Then applied anatomy. Piles or hemorrhoids. These are dilatations of the veins and they project to the lumen of the anal canal as mucous bulgings. So this dilated veins projected to the lumen of the anal canal as mucous bulgings. The internal piles occur above the pectinate line. It occurs 3, 7 and 11 o'clock positions. See, if you imagine that anus is like a clock at 3 o'clock, that is almost at the left side. Then 7 o'clock, just right to the midline. Then 11 o'clock, right side. So you are seeing this, hemorrhoids in this internal piles in these three positions, that is 3, 7 and 11. When you in the lithotomy position means that is the position wherein we keep the person for delivery. So lying on the back and the leg, the hip joint flexed and knee joint flexed, legs supported, such that perineum part is clearly seen, which we are calling as lithotomy position. And in lithotomy position, if you see the anus, 3 o'clock position will be to the left side, and 7 o'clock and 11 o'clock will be to the right side. Now anal fissure. It is due to the rupture of anal walls during passage of dry hard stool. The condition is very painful. So anal fissure is due to the rupture of anal wall. This will be very painful. So that's about the apparatus. Then vessels and nerves of the large intestine. First half of large intestine is supplied by superior mesenteric artery, and innervation is sympathetic innervation, superior mesenteric and celiac ganglia, parasympathetic innervation by vagus nerve, and the distal half of large intestine, that is from the distal 1/3 of the transverse colon, the descending colon, the sigmoid colon, the rectum and anal colon. This we are calling as distal half of large intestine. That is supplied by the inferior mesenteric artery, and the innervation is from inferior mesenteric and hypogastric plexus, and parasympathetic is from the pelvic and splenic nerves. So this is about the nerve supply and the blood supply of the proximal part of the large intestine and distal part of the large intestine. Proximal part of the large intestine includes the CAECUM, Vermiform appendix, then the right 1/3 of the transverse colon, whereas the distal part of this large intestine includes the right 2/3, left 2/3 of the transverse colon, then the descending colon, then the sigmoid colon, then rectum and anal colon, which are supplied by the inferior mesenteric artery, inferior mesenteric and hypogastric plexus, sympathetic innervation, and parasympathetic innervation is from pelvic splenic nerves. First half is from superior mesenteric artery, superior mesenteric artery is also supplying the small intestine, that is the duodenum jejunum ileum also. And sympathetic innervation, superior mesenteric and celiac ganglia. Parasympathetic is from vagus nerve. So here the important thing is the piles, the internal piles, hemorrhoids, which are present at the 3 o'clock, 7 o'clock and 11 o'clock positions when you are seeing the anus in lithotomy position. And this can rupture and lead to bleeding, and they occur above the pectinate line. And external piles occur below the pectinate line. It is very painful and does not bleed on straining while passing stress. So here we are showing the interior of the anal canal is having 3 parts. The first part is the columns of Margotni. We are seeing vertical columns of Margotni, which is lined by the simple columnar epithelium, and then the intermediate part between the Hilton's line and pectinate line, we are seeing it is lined by stratified squamous epithelium, and anal wedge lined by the skin. And here we are seeing anal walls in between the intermediate part and the proximal part. So in the rectum is a rectus means straight. Rectum is a straight structure which is used for storage of the fecal matter. And here we are seeing haastras. We are seeing a superior, middle, inferior, and these haastras are there to support the fecal matter, transverse folds of the rectum. These are walls of Huston. These are there to support the fecal matter in the rectum. Then of course descending colon, then the transverse colon. In the transverse colon, it's important that it is starting from the hepatic flexure and ending at the splenic flexure. It's about 50 centimeters length, and then we are having the descending colon, the ascending colon, and then the CAECUM and vermiform appendix. So here the surface anatomy of CAECUM. CAECUM is present below the transtubercular plane and to the right of the right lateral plane, and of course the other parts are supported by the pelvic plane. Then we are having the ileocecal opening at the junction of the transtubercular plane and right lateral plane, and 2.5 centimeters below this ileocecal orifice on the same right lateral plane we are seeing the base of the appendix. And the McBurney's point, this is very important, McBurney's point is in between a line joining the anterior superior iliac spine and the umbilicus. We are calling as transtubercular and umbilical line, and the medial 2/3 and lateral 1/3, the junction of the medial 2/3 and lateral 1/3 of this line, that is the line joining the anterior superior spine and spino-umbilical line. We are having the McBurney's point where we can feel the maximum tenderness in case of the acute appendicitis. And here we are seeing the types of CAECUM. The fetal type, wherein the apex of the CAECUM continues as vermiform appendix, that is only 2%, and infantile type, wherein the base of the CAECUM is flat and is divided into 2 equal halves, and from this depression in between the center we are seeing the appendix coming out. That is infantile type is also less, 3% only, whereas adult type is the normal one, wherein we are seeing this appendix coming from the mid point of the base of this CAECUM, which is dilated, which is flattened. Whereas in exaggerated type, this appendix is coming more towards the ileocecal junction, Now here in the large intestine, I told you, large intestine is about 6 feet in length and this tinea are about 4 feet in length. In order to accommodate the 6 feet large intestine into the tinea of 4 feet, they are having folds, large number of folds in the large intestine, which you are calling it as sacculation or hastrop. Okay, that almost finishes our class. Thank you.